Good evening, everyone, and welcome to our insightful webinar, Safe Spaces, Navigating Workplace Violence in Healthcare. Today, we'll take a look into some of the most pressing challenges in the healthcare sector, particularly concerning workplace violence, and we'll explore the latest trends and Memorial Hermann's proactive strategies, including adjustments in response to Texas's most recent SB 240 legislation, which strengthens workplace violence protections for healthcare professionals. This law aligns closely with the broader federal initiative to promote safety and accountability across the healthcare setting. Our experts will shed a light on how Memorial Hermann responds to these legislative changes, incorporating best practices and innovative approaches to foster a culture of safety. We'll also discuss the broader framework of state and federal policies, emphasizing the collective impact of these initiatives in shaping safer and more supportive workplaces. To guide us through this important conversation, we'll have two remarkable leaders with us today, and we'll start by introducing Leah Blackwell, who is the Vice President and Chief Nursing Officer at Memorial Hermann Hospital in the Texas Medical Center. Leah embodies the values of transformational and servant leadership, creating an environment where every team member can thrive. Her journey with Memorial Hermann began as a new graduate nurse in critical care, and through dedication and skill, she advanced to oversee the clinical and operational management of over 1,200 licensed beds. And as a nursing team of more than 3,900 professionals. Under her leadership, Memorial Hermann has sustained its magnet designation, a testament to its commitment to nursing excellence. Now let's turn to our next expert, Dr. Richard Holter. Dr. Holter, the Regional Director of Security at Memorial Hermann, brings over 40 years of experience in security, law enforcement, and loss prevention. Recently promoted to oversee security across the Texas Medical Center, he has a robust background, including roles as Tactical Response Team Commander and Operations Bureau Commander. Dr. Holter holds numerous degrees and certifications from a doctorate in criminal justice to credentials as a workplace violence and threat specialist. And he is passionate about cultivating safe and compassionate work environments. Leah and Dr. Holter's expertise and commitment to professionalism align perfectly with today's discussion on fostering secure and resilient healthcare settings. Thank you both, Leah and Dr. Holter, for joining us. And now let's dive into the conversation.
Awesome.
Thank you.
If you'll go to the next slide, Benson, we'll get started. Perfect. And the next one. Great. So I'm just going to pause here for a minute because anything at Memorial Hermann we do, we like to align our work to this slide. And so you'll see that our vision as an organization is to create healthier communities now and for generations to come. And you'll hear through our presentation that we've really identified that workplace violence is a community health problem. And one of the primary reasons we feel so compelled to focus on this work. You'll also notice that our first service standard is safety. Is safe. And so we're committed to the safety of our care teams, our patients, and the visitors that we serve. So you'll hear that kind of theme throughout as we move along. Next slide. So we'll spend about 40 minutes here just kind of walking through this agenda. We want to make sure that we leave time for questions at the end, so you feel free to put things in the chat. I know that Mark is monitoring that as well for us. But as we saw kind of aggressively growing workplace violence issues in our organization, really felt this call to action. I'll give you a spoiler alert, though, that we don't have the magic bullet or the complete solution. So we've made incredible strides to support our teams, but it will be a constant journey for us that requires a multifaceted approach. Next. So I think many of us can, speak to or know the statistics that are on this slide, but we didn't feel like we could start the presentation without some kind of foundational knowledge. And so OSHA really calls out that 73% of all reported incidences of workplace violence occur in the healthcare setting. And then at Press Ganey, so the data on the left side is really from Press Ganey, that greater than 2 nurses are assaulted every hour in a healthcare setting. So that equals 57 assaults a day, or 1,739 a month, or over 5,000 a quarter. The data on the right side is a mix of Press Ganey and AHRQ data. And I won't read all of those, but you can see really just some sobering numbers that really kind of led us to start this journey. Next.
Continuing our journey, if I may, Leah.
Of course.
Additional statistics here at the IHSS Foundation, the International Association of Healthcare Security and Safety Foundation in 2023, did a crime survey, of course, and provides the benchmarking that we use in a lot of our review of workplace violence. So our violent crime rate, including murder, rape, robbery, and aggravated assault, serious injuries, was 1.9 incidents per 100 beds. So if you look at that for a 1,000-bed hospital, we're looking at 19 per 1,000. So that 19 in a year of that kind of crime is very serious. But when we also look at the rate of just simple assaults, the fact that someone is slapped or someone is struck without their permission or gets shoved, a simple assault, we're talking 22 incidents per 100 beds annually, which averages out about 220 beds or 220 incidents for a 1,000-bed hospital. That's a lot of incidents to have happen. Next slide, please. Now, we know that workplace violence is endemic. It's in U.S. healthcare, it's broad, it's across the world. We're facing it, and it's one of the top problems in security that we're addressing as well, but we're using a multidisciplinary approach to do that. So the rates of assaults in hospitals, again, if you look at the trend lines, from the beginning back in 2012 up to 2021, where we're at 17.7 assaults per 100 beds. But if you look at that trend line, early on, we could probably explain because we're going through the steps of not my job. So no one has been hired to get beat up. We don't hire people to beat them up. So we have preached that from the beginning. So it was hard getting past that early on and making sure that we were getting adequate reporting. And as our reporting increased, so that our incidents showing. So we haven't really gotten to the point where we have a strong statistics to look at because we're still in the idea that we're getting all the reporting. So it's very important that workplace violence be reported so that it can be addressed. We can't do anything about it if we don't know what the incidence of workplace violence is. We know it's severe because if you go over to the other side of the slide on figure 2, if you look at that, we're looking at about 3/4 of all workplace violence assaults occur in the healthcare environment. And that's a serious problem. Next slide, please.
Awesome. So beyond the physical impact, workplace violence has a psychological impact on our teammates. So either those who were directly or indirectly engaged in an episode of workplace violence. There's either the primary victim or the secondary victim, which we consider those who witnessed or assisted in protecting their colleague. And so for these reasons, we see higher rates of absenteeism and burnout, which ultimately have a downstream impact on the quality of care and patient safety. This leads to an annual nurse turnover rate of 15 to 33% and is the leading cause of job dissatisfaction among providers, particularly nurses. Workplace violence also has an impact on the organization with increased costs associated with staff turnover, cost of injury treatment, and staff time spent away from work. These statistics and reasons, along with the very pointed feedback from our employees in employee engagement surveys, created a large call to action within our organization over the last 3 years, and we'll share our interventions over the next few slides. I'll cover the clinical ones, obviously, and then Rich will do an amazing job covering the security ones. Next. So I'll kick off by sharing our interventions that were very specific to our clinical teams. And one of those key strategies is the implementation of a comprehensive workplace violence prevention plan. So these plans outline clear policies and procedures for identifying, reporting, and addressing potential threats or incidents of violence. They also included emergency response protocols to ensure swift action when necessary. We also recognized an opportunity to put clinical expertise in the key area where violence from our behavioral health patients was occurring, which is our emergency department. So we made an intentional effort to staff embedded behavioral health nurse practitioners and/or social workers in our ERs with the goal of bringing the clinical expertise to the patient. So our TMC campus also has developed and staffed a 24/7 behavioral emergency response team or BERT team to help with early intervention huddles and respond to these events across our house. and not just in our ER. And this team consists of a behavioral health social worker, clinician, trained to deal with these highly aggressive patients and family members, and helps us work on de-escalation. The best thing I like about it and that the team here likes about it is that it removes that nurse or that caregiver from that needs to maintain a different relationship with the patient from the escalated scenario. Another key relationship was between our risk management legal team and our law enforcement and district attorney offices. They met and shared our perspectives, and we really worked to develop processes. So they met with the Harris County District Attorney's Office regarding criminal charges for those who have violence against healthcare workers. And we implemented a structured and standardized process across our organization for staff who want to follow up by pressing charges. And really our operations administrator or house supervisor in your organization is the gatekeeper of that. So helps shepherd them through the process if that's the decision that they make. So I think for our teams really creating, we support you. And if you want to hold somebody accountable, we support you there too. It was really important for us. Our teams also worked on standardizing our code green process. So that's how we respond to those aggressive patients. We may also be called a behavioral emergency code, depending on your organization. And that's when a patient, family member, or visitor displays verbal or physically aggressive behavior to our team. And the goal is to de-escalate the situation and keep everybody safe. So through our work group across the organization, we standardized our overall processes, but we also incorporated mock code greens to allow our teams the opportunity to practice their responses in a safe space so that they feel like they're able to respond appropriately and know that people are going to respond when they do escalate. The other thing that we did was we installed visible code of conduct signages throughout our facility. So implementing well-designed code of conduct signs was an essential part of our broader strategy to reduce and foster a culture of safety and respect. These code of conduct signs clearly outline acceptable and unacceptable behaviors and highlight the hospital's commitment to preventing violence. They're an important tool for us because it sets behavioral expectations, creates awareness among those who enter our hospital doors, and empowers staff to follow through on protocols related to violence prevention because they know that they'll be supported. We also engaged our frontline teams and designed public-facing signs that we call our kindness campaign, and I'll show you pictures of these when we move to the next slide. That took a more personalized approach with signs to humanize our workforce. So there are multiple versions with statements like the person caring for you is a daughter, a mother, a son, etc. And so I'll give you a peek at those on the next slide. Pre-pandemic, we had an incredible rise in workplace violence incidences, and we had but we also had a very generous visitation policy. So really throughout the pandemic, hearing the voice of our teams with that generous visitation policy felt like we needed to really revisit. We want to make sure that we're certainly meeting any regulatory standard for visitation and our patient rights through that. But maybe take a little bit less of a liberal approach, particularly in those high-risk areas like our ICUs. So we have a work group across our system working through how to manage our visitation better that will keep our patients and staff safe. We also implemented and had for years, but I think really started hardwiring and monitoring compliance with de-escalation training provided to all staff members. So we're doing our part in this training to ensure a resilient and prepared workforce. We want to make sure that they have the tools to respond when the scenarios persist. So this training equips them with the skills needed to effectively manage and diffuse volatile situations before they escalate into violence. Through realistic scenarios and role-playing exercises, our healthcare workers learn how to recognize those early warning signs, stay calm under pressure, and employ communication techniques that promote more peaceful resolutions. We currently offer 2 levels as an organization: the Essentials, which is available to all staff, and then Advanced, which is focused on our high-risk areas. Continuous training really helps make sure that our staff remain vigilant and current so they can adapt to the challenges and changes in their environment. A big component of our work was making sure our care teams have good communication across the disciplines. And so we worked on improving inter-team communication. We recently implemented a behavioral health and aggressive patient communication tool that objectively reports shift to shift the signs and symptoms of aggression and identifying triggers to escalating behavior. So what we found is, a nurse may witness a couple minor escalations one shift, and then the next shift, she doesn't communicate that, right? Because she doesn't think that much about it. And then the next shift, the person has 5 of those. And before we knew it, we were having kind of full-blown scenarios. And could we have caught that earlier? So this handoff tool really helps them be able to communicate between shifts anything that they're seeing. Also, with our recent Epic Go Live, we were able to build in a banner alert when we have an aggressive patient or a patient with a history of aggression from a previous admission to really create awareness around anybody viewing that chart. So we felt like that was an important part of making sure that we had just prior line of sight, particularly if they've had previous admissions with us. We know one key element for managing workplace violence is awareness, and we know workplace violence incidences are also underreported. And so we moved forward with developing a workplace violence icon in our variance reporting system. Previously, people felt like it was cumbersome. They had to go through kind of multiple menus to get there. So now right on the homepage is a workplace violence icon. They can click that and report that incident pretty easily. And we feel like it allows us to have better information and tracking. The last and probably most vital tool is really boundary setting conversations with aggressive and manipulative patients. And so these are crucial to us really mitigating workplace violence in healthcare. And so leaders and house supervisors provide clear boundaries and set expectations. So when we tend to have that patient that's continuing to escalate, really everybody meeting and getting on the same page and on what our boundaries are going to be, and then having that boundary setting conversation so that we all know that we're on the same page. And that works particularly well with visitors and families where we have a little more leeway to manage their visitation or their time in the room with the patient. So we can move on, and Rich will cover all of the security items. Oh, let me cover this really quick. These are our code of conduct and kindness signs. So I'm actually showing you the public facing and the non-public facing sign. And so the first one on the left is the public facing, and you can see that these are posted everywhere just to really humanize our workforce. And these were designed by our marketing team with a lot of input from our emergency room department nurses. And then on the right side, we really felt like we needed a message out to our teams that said that we support you and we want you to report. And so these are staff-facing areas like break rooms where this signage is placed and really helped us get the message out that it's important and it matters and we want to hear what's happening. Next.
Yeah, so we need to talk a little bit about security support and how that's worked. Keeping in mind that Memorial Hermann has demonstrated a strong support for security in dealing with workplace violence from leadership through the entire Memorial Hermann community. So if we look at enhancing our security personnel and EVs, what we've done is in the past, we didn't have security officers in all our emergency departments. And this resulted in the violence occurring there and taking time for the officers to respond. It also involved the idea that the officer is present and actually doing the de-escalation at the time that the events occur if we have the officer present in the emergency department rather than having to respond from somewhere else. So we have made the step to having officers in all our emergency departments. And also we have officers even in our clinics and offsite locations across our system. Something we're very proud of and is a differentiator for us is our STEPU, which is our Security Training, Education, and Professionalization Unit. In that realm, we've actually, we have our own range for firearms training that's in Conroe, Texas. We also have our own training center. And in that training center, we recently installed a firearms training simulator, which is actually a simulator that you can use to do de-escalation training because it doesn't have to involve firearm, but it has over 300 different scenarios in which a patient is actually acting up and gives a clinician, a security officer, or anyone in the Memorial Hermann community the opportunity to go through the steps in de-escalation and actually replay it back and critique their own behavior. We also have weapons detection in half of our hospitals right now, with the intent to roll it out to all of our hospitals. But in the Texas Medical Center, we've had over 380,000 scans during this year. So that's how many patient contacts basically we've had going through our weapons detection. And it's resulted in just over 400 weapons being seized. Besides those weapons that we've actually seized during scanning, we also implemented something a little unique, and that's an amnesty box. And if you went to the library and you had an overdue book and you went back and wanted to return the book, they often had amnesty boxes where you wouldn't get in trouble for your overdue book. Well, it's similar. It looks like a mailbox or a library depository. But when a patient, a visitor, someone comes into the hospital and they're carrying a weapon that they know shouldn't probably go through the hospital, they get the opportunity at the last time at the door to drop that weapon in the amnesty box, no questions asked, and it keeps the weapon outside the hospital, which is what we want to do in the first place. Now, purposeful rounding is a manifestation actually of our multidisciplinary. It's going out and rounding on the units themselves. Our officers make regular rounding and they make contact. They're not just strolling through the unit. They're making contact with our charge nurses and our bedside nurses and identifying the problems that they're having to deal with and offering support in dealing with those issues. At the same time, they're going through and doing what we call mini drills, and those mini drills may be exercises in workplace violence and maybe active shooter situations in which they talk through and walk through the situations, helping everybody get on board for this multidisciplinary approach. We also are looking at and enacting right now specially trained canines. We're in the process of rolling this program out to 2 of our hospitals as a pilot, in which these canines will be trained to detect weapons and firearms themselves, their ammunition, as well as any explosives. And of course, they're canines, so they're also going to be a nice dog going through the hospital, and people will recognize that. There'll be German Shepherds, so everybody loves to see a German Shepherd come through. But our officers will be highly trained in handling those canines as we select the officers and use them for this process. And again, that was a multidisciplinary approach that was provided by our foundation, providing the initial funding for that and allowing us to do this because recognizing the need and recognize how it can help in the world of workplace violence. We're right now in the process of training all our officers in TASER and body-worn camera deployment and deploying those. Actually, by tomorrow, we'll have TASER starting to be deployed in the Texas Medical Center. Our officers are already wearing body-worn cameras, state-of-the-art, in which there can actually be two-way communication. When the TASER is drawn, it actually activates the body-worn camera. It is not a spy for the security department. It actually is designed to protect and also to help train security officers because they, again, can go back and we can address training needs based on how they handle the situation. And then we're looking at a system-wide security operations center. There is a security operations center at the Texas Medical Center, but we're looking at expanding that and deploying a security operations center that is either regionalized or centralized that will encompass our entire system. So a lot of changes going on. A lot of them are precipitated by a response to workplace violence. Next slide, please.
All right, so you heard Rich say a handful of times in there that it's a really, truly is a multidisciplinary approach. And I couldn't agree more. We cannot do what we do and for our teams without our security partners, but it also takes some others to help support our teams from an emotional and mental well-being standpoint. Our chaplains are key in this. Here at the TMC campus, we actually have a chaplain that's just dedicated to physician and employee wellness and well-being. And so we're ecstatic to have that. I know that's not a resource not everybody gets to have, but excited. So all of our chaplains across the system are available to help with immediate emotional support following an event. They will show up to Code Greens and be sort of on standby when something happens. So we always appreciate when they're there just for that initial touch point with the team that was involved in the incident. We also do critical incident debriefings. And so our chaplains are also trained in the International Critical Incident Stress Foundation to help healthcare teams process emotional stress and unusually traumatic events that are encountered when they're here at work. So whether it's workplace violence or not, we do engage them often. We also have a pretty extraordinary Code Lilac program across our system, which is a multidisciplinary 24/7 peer-to-peer support program that offers emotional support to our workforce members who have experienced a stressful patient or work-related event. It's one of the largest and most robust hospital-based peer responder programs in the country. And currently we have more than 400 Code Lilac volunteers who are peer responders. And part of 17 teams, we also have a 24/7 hotline that our teams can call and be connected so that there really truly is 24/7 access. Our goal is to provide that psychological first aid, with compassionate, non-judgmental, non-punitive, confidential support from their colleagues. And then the last thing we have is that we have wellness therapists who are on site at many of our campuses who are available to help employees who have encountered workplace violence. So that's sort of that more continual support if they need a few sessions with the wellness therapist. If they're not sleeping or doing well post events, we want to make sure that they get ongoing support. This is all underpinned with our normal employee assistance program initiatives as well. They also have that as support. Next. Okay, so I wanted to switch gears a little bit. So we've talked about what Memorial Hermann is doing within our organization, but we're also doing a lot with advocacy and partnering with our legislative partners both at the state and federal level on a few key policies. And so really we've engaged our government relations team through these efforts and really helps them understand the impact and how they can advocate as well. Our overall goal is to really have policies that support prevention, but also accountability for those that do have workplace violence against our healthcare workers. So if you go to the next slide, Benson. Just wanted to share some pieces of legislation that happened in the 88th session, which was in 2023. So we're gearing up now for the 89th session that'll start in January. But in that 88th session, a few bills passed that address workplace violence or are based off healthcare workplace violence incidences that occurred previously. So myself and another Memorial Hermann CNO had the honor of testifying on behalf and in support of SB 240 during that legislative session to share our perspectives and the voices of our care team. These were all effective just over a year ago in September, but SB 240, the plans had to be implemented in September 1 of 2024, so just a couple of months ago. I'll start with SB 840, which really increases the penalty for assaulting healthcare workers from a misdemeanor to a felony. And this applies to all healthcare workers across all settings. So nurses, physicians, maintenance staff, patient access, and others. The purpose was, it was named after two healthcare workers who were tragically killed in 2022. I think most people know the Methodist event in Dallas, and aims to protect healthcare staff by increasing the penalty for assaulting healthcare workers. A few provisions is that it elevates that offense for assault. It used to previously just apply to first responders only. But really elevates that for causing bodily injury to healthcare workers, specifically those employed or working in hospitals. So if someone knowingly assaults hospital personnel while they're performing duties, the offense is reclassified from a misdemeanor to a third-degree felony. SB 1004 enhances the penalty for removing an ankle monitor or other electronic monitoring devices for individuals on parole or other types of community supervision. And this was passed in response to the Methodist Dallas Medical Center shooting. That individual had removed his ankle bracelet before entering the facility for that shooting. So really in response to that event, the bill addresses public safety by criminalizing the removing or tampering of these devices. A few key provisions. It was previously considered an administrative violation to do that, and is now a felony offense. Offenders who cut off their monitor will face immediate incarceration or an additional felony charge. This section does not apply to the removal or disabling of a tracking device by a healthcare provider in order for medical necessity. So I do want to call that part out. And then SB 240 is the big piece of workplace violence legislation that was passed, introduced by Donna Howard, who is a nurse herself. She started her career down in Austin, and so really appreciated her bringing this forward. So it's designed to protect healthcare workers from violence by helping healthcare organizations prioritize their safety. So it does sort of put a process and structure in place for all organizations. I like to say when it talks about a facility, they really look at facilities that employ 2 or more nurses. So really think about those rural areas or those small ambulatory centers that probably don't have robust programs like Memorial Hermann. So that's why I tell people it's really important that we still advocate for that structure and process. It is designed similarly, if you know the staffing effectiveness law that nursing follows, by having to have committees. It is very similar to that in how it's written. So it requires facilities to establish a workplace violence prevention plan and policy, to provide annual workplace violence training, develop a system for responding to and investigating incidences, and then provide care for employees who are assaulted at work. So you've seen kind of through our presentation of what Memorial Hermann is doing, we check all of those boxes. It also has to be reported up. And so we have campus-based workplace violence committees that report to our system employee health committee, which then reports up to the board. So we make sure that we check that checks and balances, that it's getting reported to the board, all the work that's happening. Next. So I'll talk about 2 pieces of federal legislation that are in progress currently. So the first one is Safety from Violence for Healthcare Employees Act, or the SAVE Act. And really what it does is it protects healthcare workers, and it makes workplace violence against healthcare workers and gives federal protection very similar to the airline industry, and makes it a felony. So I just provided the AHA has position statements on this one. And so just provided a couple of their bullets that the number of violent attacks has increased, and they want to make sure that we're creating safer environments by having the accountability on the abuser part. The second one that AHA actually opposes is the Workplace Violence Prevention for Healthcare and Social Service Workers Act. So it mandates OSHA to create a standard requiring employers in healthcare and social services to develop and implement workplace violence prevention plans, which exactly mirrors SB 240 that we just talked about, and is very aligned with the Joint Commission standards that we all have to follow. So they actually oppose it because they feel like it really just strives, puts a lot of prohibitive costs on the organizations. Particularly, it does have fines and things associated with it, but really concerns about the rural and underserved area if this were to pass, which could strain their resources and jeopardize patient care. So really that increased burden was struggling to maintain services. So the AHA is actually opposed to this. So you can form your own opinion and talk to your GR team and see what your hospital stance is. But that is the AHA stance. Next. I just quickly, if you weren't aware of the TJC standard, outlined what they ask of us as an accredited organization to do to provide a safer organization. So again, having that workplace violence prevention system, defining workplace violence, establishing leadership oversight of a program, fine-tuning the policies and procedures, creating easy and accessible reporting systems, analyzing, tracking, and trending data, and then staff training and education. So you'll see a lot of the components are mirrored, and so it just feels like duplicative policies and legislation. Next. All right, so I think if we were to talk about how you could help where you are, you could advocate federally for the SAFE Act and reach out to your congressperson. So it has very strong bipartisan support, both Republican and Democrat support in the House and the Senate. So there is a House bill version and a Senate bill version. And then share stories. If you are to interact with anybody, any member of your legislative team, if they come to your hospital for a tour or you have those interactions, just make sure that you're sharing those stories and impact of workplace violence. I do a lot of advocacy on a federal and state level, and I'm always surprised and a little shocked that they don't know what happens to our employees and the level of violence and the things that happen. And so if you have a story of something, feel free to share that, because I think it does shape and change their perspectives as they go into these sessions and are able to sign on and sponsor various pieces of legislation. And then I think just empower your team. So engage your teams for feedback and really lean into empathy. Anytime I follow up with an employee post-event, or just listen to them and their frustrations in meetings or huddles, it's always so appreciated. I think they just want to be heard. And so I think if Rich and I could just share anything, it's that it is a very emotional response by our teammates. And so make sure that you're really leaning into that empathy, because it is very personal to them. So that would be sort of my piece of advice that I've learned through my journey in hospital administration and just leadership, is just really giving them that voice and that space to share their concerns. Next. So I'll just sort of leave with my kind of final parting statement, and I know Rich has one too, but workplace violence is a significant challenge in healthcare, and it requires collaboration on all levels and a multifaceted approach. There's not one single intervention or one single team or leader that's going to solve this on their own. And so while Rich and I are here on behalf of Memorial Hermann, there are lines and lines of leaders behind us that would have the same passion and the same level of knowledge about this work, because it is incredibly important to us. So, and then I'll hand it over to Rich for kind of his final thoughts.
Thank you, Leah. So for me, this kind of says it all. Workplace violence is a community issue. Hospitals are not apart from the community. They are a part of the community. And when an issue happens in healthcare, you have to look at all the different impacts. So if you wanted to develop a 5-minute elevator speech in which you talk to someone about the problems in healthcare, one of those problems has to be workplace violence, but it also impacts the community as a whole. Think about the turnover. Think about the productivity in the healthcare because of the disruption from workplace violence. Think about the fear the employees are going through. Nurses don't become nurses to be putting themselves at risk and be fearful of their job. And think about all the patient disruption that occurs because of workplace violence. It is clearly a community issue. And I urge you to develop that elevator speech and take advantage of it every chance you get. Thank you.
Thank you, Rich. So I think, Vince, I think we have one more slide. So I think just to wrap up, we kind of put what we think is probably the most sobering statistic for that elevator speech that Rich talked about, knowing that it creates a large impact both on individuals and the healthcare system, and how important it is to provide support to your teams and your employees. We talk about it all the time. So Eric, Rich, and I, we're constantly telling them what we're doing because we want them to feel that they're supported. And if we're not managing that message, they feel like nothing's being done. And so we're constantly saying, hey, we have this new initiative. Hey, we want your feedback on this. Eric and I actually do town halls. And so we did some in September, and we're trying to do those on an every 6-month rotation just to keep our teams updated and to continuously hear their feedback. And then work to prevent workplace violence through advocacy and that team engagement. So can't say any more about advocacy, but it's such a huge part of the work to create awareness outside of our organizations. All right. think that's it. I think we're open for questions and like right on time too, Vincent.
Mark asked a question of what happens to the weapons that are turned in or confiscated.
Yeah, so the weapons that are legal to possess that they turn in because they're caught during the scan are returned to them after the patient or visitor leaves the hospital. They can actually recover those. The ones that are dropped in the amnesty box are a giveaway. So they come to us and then they are destroyed.
And then Emma asked a question, how do you measure the success of your workplace violence interventions?
Yeah, so I'll talk a little bit about the ones I spoke to, and then I'll let Rich follow up on his. But I think, we do mock code greens, and so we look at response time and comfort level and debriefing with the employees after those things. We are looking at the number of employees that decide to press charges and just making sure that they feel comfortable with that process. That is a very personal decision and that they need to make themselves, because that will be a journey if those charges are accepted. We look at our de-escalation training. So I get a monthly report about de-escalation and compliance with doing their education on the every 2-year rotation, as well as the advanced training. So making sure, like in our ER, that they're getting the essentials and the advanced, and that we're following up with those employees who haven't done the class yet. We monitor reporting, but we honestly want to see more reporting. So we know it's underreported because people think it's just my job or it was just that one time. And so we actually don't want to see reporting go down. We want to just make sure people are feel comfortable and psychologically safe to report, and that there won't be any retaliation, or that we're going to address the concern. And then we track when my patient relations team is involved in those boundary setting conversations, we track those response teams. And then here at TMC, we have the BERT team, which is that behavioral emergency response team. We also have data on that we review monthly in our behavioral health meeting that we have here for the campus.
So in security, the important things for us to track, of course, are the number of incidents of workplace violence. We track those for our incident database, so our officers make investigative reports every time they're involved in responding to an incident of workplace violence. That's actually correlated with our other hospital records, because we want to get to the record of truth, which are VRS, our variance reporting system. And so we look at that and compare those against those to make sure that we're getting to the record. We also have a threat assessment team. So we look at the number of threats that are coming into the hospital as well, because we use a multidisciplinary approach to threats and resolving those and actually developing safety plans to ensure the safety of our staff and our visitors and patients. So looking at those and the variance that we see and how many are those statistics that we see, and hopefully we're seeing a decrease in that. Initially, we understand that we're going to see an increase because we're really working on the reporting. We want to make sure that we capture every incident of workplace violence with that idea that it's not my job. Clinical staff should not be worrying about workplace violence, shouldn't be part of their job. So every one of those incidents in their job right now is just to report it and let the professionals, security, and our BERT team, who are experts at this, address those issues of workplace violence rather than the team having to do that. We also look at the number of injuries from workplace violence. That's a very important statistic for us. Security's job actually is to displace some of that. So if there's going to be someone injured, our officers are trained, they're equipped, and they're properly vetted to address those issues of workplace violence, whereas our nurses are not properly equipped to deal with it. And so we want to take the heat off of our nursing staff, our clinical staff, by stepping in the way and addressing those issues of workplace violence without resulting in injury to clinical or other staff.
I do have a question. When it comes to tackling workplace violence, it's such a multifaceted approach that involves so many different components. Kind of from the clinical and the security standpoint, what is the hardest part or hardest obstacle to overcome when implementing a culture of workplace violence prevention?
Ooh, that's a good question.
It is a good question.
I mean, I would say it's what we talked about, people feeling comfortable to report. I mean, I got something across my desk today and it happened 2 weeks ago and I'm like, why didn't you report this? You know, and so and she was like, oh, it's just one time. And, you know, I'm like, and it was like a sexual innuendo, right? And so they have to feel comfortable to report all of those things. And sometimes they think, oh, it was just that one time. And, you know, that he grabbed me. And so it's just, I think people reporting so that we can have a better understanding of what's happening and continue to develop and refine the interventions that we have.
Yeah, and I would add, Benson, that that reporting has been the reason why we've developed a very heavy educational piece on workplace violence. People need to understand what workplace violence is and some of the steps to prevent it. So we provide that education on an ongoing basis, such as Leah said with our town hall, but we also do nursing meeting and charge nurse meetings. And we go every time someone wants to listen to us about workplace violence, we'll talk about workplace violence.
All right,
Yeah,
so Mark,
I was just gonna say, I agree with Rich. I mean, when we really first started this, we would say, what's workplace violence? And it's like, oh, I got hit or slapped or kicked. Right? Not like, oh, I was grabbed inappropriately, you know, from behind, or verbal or cursing or racial. They didn't think any of that was workplace violence.
Mark asked a question. He said, I was recently flagged at the entrance of a sporting site for a metal wallet for a new tech where I did not go through a metal detector. Can you talk more about advances in weapon detection, particularly these units that are not a walk-through metal detector?
Yeah, proximity.
Also,
Proximity detectors, Benson, are becoming more and more common. And those proximity detectors use advanced analytics. They can actually identify on the person's body where the idea might be, where there might be a weapon located. And they picture it right on video, and we're allowed to identify it and locate that when we do a search. So proximity detectors don't require you having to walk through an arch, right? So they can be a single pole, or they can be just a block mounted on the floor. So it's becoming more and more common. You're going to see more and more weapon detection across different industries, but healthcare, it's becoming very prominent because we have to protect our hospitals from having weaponry get inside the hospital.
I agree. How easy it is to bring a weapon into an emergency room is strikingly easy.
Yes.
Also, Mark asked, what more can be done to educate those entering our facilities, to educate them about the increased penalties and what is not appropriate in the healthcare setting?
Yeah, signage is something that we use prominently, so that everyone is given advance notice before they enter the building that weapons are prohibited and that what the penalties are. We also have the signage, as Lee has pointed out, in regard to what the penalties are if you assault a healthcare worker, and don't want to address that. So signage is probably the best thing to get the word out, but also those elevator speeches, those conversations, that advocacy out there, and making sure that we get the word out.
Awesome. Well, any more questions from the audience?
Is there a resource in terms of like case studies when you do have, big events like we've had in Dallas for either on the security side or on the workplace violence side for review and learning?
Leah, I can speak to the security side, of course. So we have the Association of Threat Assessment Professionals that has a violence journal that a lot of research is published in. So you get a lot of ongoing research there. The International Association of Healthcare Security and Safety publishes crime data all the time, and also has articles, peer-reviewed articles, and review of state-of-the-art technology and techniques to combat workplace violence. It's, again, as that we said in the beginning, it's probably the biggest problem facing healthcare, and everyone's working to solve it.
Yeah, I'll agree. I don't know that there's specific case studies, but I was actually just telling Rich earlier today, I got 2 nursing journals in the mail this week, and they're both heavily focused on with articles about workplace violence. So things other organizations are doing are trying. And I think, just in the nursing leadership space, nurses they want to serve, right? And we never want a nurse to get to a crossroads where they're picking safety over service. And I think that that's where we will get. We are always keeping an eye on the growing nursing shortage, and we can't have things like we are already going to be short nurses by 2032. And Houston's probably going to have the greatest shortage in Texas. And so we can't have things like this happening when we're not already producing enough nurses to cover the shortage. So they need to feel safe. They need to feel like it's a healthy work environment. And so it also has that bigger impact, right? Like it can drive the nursing shortage one way or another. So.
Awesome. Well, anyone have any more questions before? Oh, Simone Ashley asked, are there any plans for the ambulatory settings such as MHMG and OPID and SMR in education for these locations, since they are detached from the acute care sites, but workplace violence is still a concern at these locations?
I know from my experience, I've given numerous presentations on workplace violence to those type of locations. And we are starting to staff some of those locations, or emergency rooms, offsite emergency centers. So we take those responsibilities very closely to heart. But again, smaller locations, it's difficult to staff, but they can always report to law enforcement directly if there's an issue, and we encourage it. If they feel there's a threat, that they report immediately and report to law enforcement, and then contact security so that we can follow up and help educate.
Yeah, I'll just, actually, there is a large system work group that works on all of this, and it's, there's was an ER arm of it, an inpatient arm of it. And I know that there's a lot of work from an outpatient space, and so certainly happy to share anything else specific to that. I think education, like Rich said, and just making sure that they're aware, and then making sure that they understand the offering for the team training or the de-escalation training is important for us, and how to manage those situations, making sure they have their code green plan ready, and participate in those mock code greens and work with security. So they are being incorporated. I'm not sure probably as robustly as the ER inpatient sides, but certainly I know that there's a work group focused on that.
Awesome. Any more questions? All right, if there's no more questions, I'd like to thank Leah and Dr. Holter for doing this presentation today. I thought it was very insightful, and I learned a lot about workplace violence and prevention, and a lot between the legislative laws that are being in place right now. And I really thank you guys for coming and doing this presentation.
My pleasure.
We're happy to do it. Thanks for letting us share.
All right. And thank you everyone for coming and attending this presentation. I hope everyone has a good rest of your day.
Thank you.